Hello, my name is Dr. Vonette Fay, and I'm a professor of clinical nursing at UT Health Houston School of Nursing. I'm also faculty with the Houston Gerontologic Education Center. The following presentation is for the use of certified nursing assistants and caregivers. This slide presentation is not intended for continuing education credits. This project is funded by a grant from HRSA, Health Resources and Service Administration, of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in 2010. The objectives of this presentation are that the students will be able to identify the stages of grief, list life experiences that may affect a person's attitudes about death, explain bedside care for the dying patient, list common clinical manifestations seen when a person is approaching death, explain postmortem care, and define the term hospice and related goals of care, and outline the importance of caregiver support. Let's talk a minute about the stages of grief. Death may be either sudden or it may be expected. Those people with terminal illnesses, that is, diseases or conditions that will eventually lead to death, and the elderly may have time to plan for death. The stages of grief discussed in this lecture are in accordance with Dr. Elizabeth Kubler-Ross's book on death and dying. The stages of grief may apply to both the patient and their families. The first stage of grief is denial. People in the denial stage, this can be the patient or their family, may refuse to believe that they are dying. They often believe that a mistake has been made and may ask that lab tests be repeated, and they may seek a second or even a third opinion. They may talk about the future and completely avoid discussion about their illnesses. They may act like they're not dying, that this just really isn't happening. The second stage of grief is anger. This stage begins when the person begins to process the possibility of their death, and they may develop anger about different aspects of their life and of this situation. They may be angry that they're dying. They may talk about the fact that they are too young to die, that they've always taken care of themselves, they did everything right, that this just isn't fair. The anger may be directed at staff, visitors, roommates, family, and friends. It's important to remember that anger is normal and healthy reaction, and that the caregiver should not take the anger personally. The third stage of grief is bargaining. Once a person believes that they are really dying, they may actually begin to bargain. This bargain may include negotiations with God, depending on their religious belief, the deity that affects them. They try to bargain for their recovery. An example might be, God, I'll go to church every Sunday if you'll only cure me. The fourth stage of grief is depression. As the dying person becomes physically weaker or symptoms worsen, the person may become deeply depressed. This may exhibit itself through crying or withdrawal. They may be unable to perform simple activities. They just don't have the emotional energy to do these things. Caregivers will need to provide both physical support, emotional support. Sometimes it's a listening ear, and you need to be understanding. The fifth stage of grief is acceptance. Most people are able eventually to accept death and begin to prepare. They may ask for an attorney or an accountant. They want to get their legal and monetary affairs in order. They begin to arrange with loved ones and friends to take care of people or things after they are gone. They will plan for their funeral and religious services. They may begin at times to be able to reflect on their life and to say their goodbyes, and they begin to become more emotionally detached. Let's talk for a minute about what shapes our attitudes about death. Death can be a very sensitive and difficult topic for many people to discuss. Feelings and attitudes about death may be formed by many factors. One factor may be our experience with death. Someone who has gone through dealing with other people's deaths may have a different understanding of death than someone who has never had the opportunity to deal with a close person who has died. Personality types can also impact our ability or our attitude about death. Some people are more open and expressive and maybe have an easier time of talking about death and coping with death than a person who is very reserved and quiet. Sharing one's feelings is a way to work through the fears and concern about your upcoming death. Religious practices and beliefs affect the person's experience with death. These include the process of dying, the rituals at the time of death, issues of burial versus cremation, services to be held after death, and the mourning customs of the group. For example, Orthodox Jews may not believe in viewing the body after death. Belief about what happens after death can also influence our grieving. Those who believe in an afterlife, such as heaven, may find comfort in this belief. And finally, our cultural background. The practices that people have growing up affect how they deal with death and with the death experience. Let's take a minute and talk about how to care for the dying person and to identify common signs and symptoms of approaching death. Not everyone experiences the same symptoms when dying, but caregivers should follow certain guidelines to help keep the person most comfortable. These guidelines we'll be talking about are the issue of diminishing senses, nutritional needs, care of the mouth and nose, skin care, comfort, the environment, and emotional and spiritual support. Care of the dying person, we talk about their diminished senses. This can be their hearing, their vision, their ability to speak, and nonverbal responses. The things that you may want to do are provide an environment that has reduced glare and keeping the room lights low. Hearing is generally the last sense to leave the body, so speak in normal tones. Be sure that you inform the person of what's happening in their room or what's going to happen during a procedure. Do not expect a response or ask too many questions, but encourage the family to also talk to the patient, to talk about pleasant things, about things that are going on in their daily life, reminisce with them, and keep in mind that because they may be nonverbal, you're going to have to watch the body language of the person to determine what their needs are. Let's talk a little bit about their nutritional needs. As people near death, their eating and drinking will decrease. You may want to offer ice chips. Cold liquids tend to be tolerated or appreciated more than hot liquids. And remember that gelatin, ice cream, frozen yogurts, Jell-O are options as well. When caring for the dying patient, care of the mouth and nose is very important. Mouth care should be given often, every 2 hours if the person is unconscious. Keep the mouth moist with swabs and keep the lips and the nose lubricated. When a person is unconscious, you want to use the least amount of liquid possible for mouth care to prevent aspiration. And aspiration is the inhaling of food, liquids, or foreign materials into the lungs. And aspiration can lead to pneumonia and can cause death. Turning the patient to the side while administering health and mouth care may help prevent aspiration. When caring for the dying patient, skin care is very, very important. You want to check for incontinence regularly and provide care to prevent skin breakdown. You want to give bed baths as needed. Some individuals may perspire greatly, toward the end of life, and you want to give bed baths frequently. The goal is to keep the skin clean and dry. Remember to change the sheets and clothes as needed and to keep them wrinkle-free. Pressure ulcers are a big concern for caregivers, and we must do what we can to avoid them. Repositioning the patient, reporting signs of skin breakdown to your supervisor, providing frequent back rubs with lotion to increase circulation to muscles and also to relax the patient. Comfort is a major part of caring for a dying patient. No dying patient should be in pain. Pain management is a basic and expected care need for individuals who are dying. Caregivers should observe them for signs of pain and report this to the supervisor. Frequent position changes, back massage, skin care, mouth care, and proper body alignment also help in the management of pain. Body temperature usually rises as death approaches. Heat can be managed by washing hands and face and the body with cool water or placing cool cloth under the armpits, neck, and on the forehead. Fever may also cause chills. The individual may need extra blankets if they're too cool. Some patients may have a PCA, which is a patient-controlled analgesic device that helps them with their pain meds. But frequently, this is not the case, and we need to observe them for pain and give them pain medications as required. The environment. With the dying patient, it's important to provide as home-like and as comfortable an environment as possible. Display favorite objects and photographs where the patient can see. Do ensure that the room is comfortable with appropriate lighting and proper ventilation. You don't want it too hot or too cold or with the fan blowing directly on the individual. Leave the call button in reach for every patient, regardless if they are aware of their surroundings or not. Finally, let's talk about emotional and spiritual support. Death can be a frightening experience for some patients. Listening may be one of the most important things that a caregiver can provide. Report signs of agitation and fear to your supervisors. People need a quiet, reassuring presence. They need touch, so don't be afraid to deal with patients and their families. Don't avoid them. Don't deny that death is approaching, or tell them that a person that we just don't know, when nobody can tell when or how death will occur. Give accurate information and do it in a reassuring way. Provide clergy support if requested, and private time for the patient and the family to be with the clergy. Don't discuss your own religious beliefs or make recommendations to family or friends. Death can be sudden or it can be gradual, but there are usually certain physical changes that are signs and symptoms of death. Vital signs and skin color are often affected. Disorientation, confusion, reduced responsiveness may occur. They begin to sleep more. Vision, taste, and touch usually diminish. And remember, hearing usually present until death occurs. What signs may be present when death is approaching? Here again, there may be changes in vision. They have blurred or failing vision, unfocused eyes. They may have impaired speech and a diminished sensation to touch. There may be loss of movement and muscle tone and feeling. And there will be a rise or below normal body temperatures. The pulse may be weak and it can be abnormally slow or fast. And they may have altered periods of slow, irregular respirations and rapid, shallow respirations. This is called Cheyne-Stokes respirations. They may have a rattling or a gurgling sound during respiration. Their skin may be cold and pale. They have mottling. It's a bruise-like appearance, spotting or blotching of the skin. This is caused by poor circulation. Here again, they may have increased perspiration. They may become incontinent, and they may become disoriented or confused. Let's take a moment to talk about postmortem care. This is care after the death of an individual. Caregivers need to be sensitive to families once their loved ones have passed away. But when you are asked to care for a person after death, you need to be sure that you can move the body. It may already become a little bit more rigid and stiff. You need to bathe the body gently. You want to avoid any bruising. And you may want to place a drainage pad under the head or in the perineal area. Be sure to follow standard precautions. Use gloves. Do not remove any tubes or other equipment. This is usually done by the nurse, or it may be done by the funeral home. You want to position the patient on their back with their legs straight and their arms folded across their abdomen with a small pillow under their head. Be sure that you follow facility and agency policy about personal items. If the individual has jewelry on, you want to check to see if it needs to be removed. And always remember to have a witness and document what personal items were returned to the family members. You want to then, after the funeral home has come and taken the individual away, you would want to clean the room, strip the bed, do any housekeeping or disinfectant. You may want to open the windows to air out the room. You want to document all of this according to agency policy and procedures. Families may want to sit with their relative after death has occurred and wait for the funeral home to come. They want to be able to say goodbye, and they may have specific cultural or religious practices that they feel need to be done right after death. The staff and you as caregivers need to be very supportive of the family and their needs at this very difficult time. Let's talk for just a minute about hospice. Hospice care is a term used for special care for dying patients' needs. Hospice uses a holistic approach. It treats the person's physical, emotional, spiritual, and social needs. Hospice can occur and can be given 24 hours a day, 7 days a week. It is available with a doctor's order. There is always a nurse on call to answer questions and make visits and solve problems. You can have hospice care in hospitals, long-term care facilities, and in the home. Hospice can be located anywhere the person who is dying is, and they can be treated with dignity by caregivers. Let's talk and define the goals of hospice. Hospice helps to meet all the needs of the dying patient. The person and the family are directly involved in care decision. The person is encouraged to participate in family life and decision making for as long as possible. It's important to realize that the goal of hospice care are not the same as long-term care, hospital care, or home care. Long-term and home care are focused on recovery or the ability to provide self-care. Hospice focuses on maintaining comfort and dignity for a person who is receiving care during the dying process. Caregivers need to be aware of these differences and change the focus of their care for the hospice client. Caregivers should remain focused on pain relief and control. Caregivers should help the person to maintain independence for as long as possible, but eventually the caregivers will need to meet all the person's basic needs. So who's on the hospice team? This is doctors, nurses, social workers, counselors, nursing assistants, home health aides, therapists, clergy, and then also dietitians and volunteers, but mainly don't forget to include the patient and the family on this very important team. Okay, let's talk about the goals of the hospice program. Attitudes and skills useful to the caregivers when providing hospice care include being a good listener and providing comfort. Never push anyone to talk or confide in you unless they're willing. Respect privacy and independence. And then also you need to be sensitive to the individual needs and ask the family or friends how you can best help. Include family in the conversation and in the care. And then develop and explore feelings about death and dying. This can be for the patient who is dying, or it can be for their family and friends. One thing we need to talk about is caring for the caregiver. Talking about supportive measures for the caregiver, and this caregiver can be the nursing assistant, it can be family, friends, non-paid caregivers. We need to be sure that they keep their own needs in mind and learn to take care of themselves while caring for others. Hospice care can be draining physically and psychologically, and burnout can be easy to experience. What is burnout? Burnout is a state of mental or physical exhaustion that is caused by stress. Caregiver burnout can be facilitated when the caregiver ignores their own needs. There are 3 main things that a caregiver can focus on to avoid burnout and keep their own health up to par. And 1 is recognizing the stress. 2 is caring for the caregiver. And 3 is taking breaks. We'll talk about these a little further. What are some supportive measures that caregivers can take? And 1 is recognizing stress. When the caregiver simply realizes how stressful the work is with people who are dying, that's the first step in caring for him or herself. Talking to a counselor about experiences at work can help to understand the work through your feelings. Remember, when meeting with a counselor, certain information is still confidential. You need to also eat right, you need to exercise, and you need to get some rest. You need to also think about caring for your own emotional health and do things for you. This may include reading, playing an instrument, spending time with your family. Take time for religious practices. If the caregiver is religious, take time to go to church for your own prayer or meditation time. Meeting a caregiver's own needs allows her or him to best meet the needs of the person who is dying. Let's talk about taking a break. Finding even 10 minutes to sit down and relax, or maybe it's walking away from the bedside, walking up and down the hall, stretch. This may be enough of a break in some situations to produce positive effects for the caregiver. It's important to take these breaks when working with people who are dying. You need to care for yourself. Don't skip lunch. Don't skip going out and taking your breaks. Remember that you make a huge difference. Never forget that the work you do with patients, family, friends can be life-changing. Your smile, a moment to stop and listen to the patient, to talk with families, to reassure them, a friendly smile to a grieving spouse. These things mean so much. You are an important part of the team. And here are our references. Thank you for your attention and for viewing this presentation.